Hello, welcome back to this series on nuclear medicine bone scintigraphy. So today we're just going to talk about soft tissue disease on bone scintigrams, and let's get straight to it. So this is one of the most obvious soft tissue abnormalities that we see at bone scintigraphy. Now I think I mentioned back in one of my earlier talks that the tracer is cleared through the urinary tract. So here we have our bladder with quite a large bladder here in this case, and we can see that both ureters are dilated and there's hydronephrosis. We can just vaguely see it here on the right side, probably seen a little bit better on the anterior view, but it's quite clear on the left. So this patient has bilateral hydronephrosis, both ureters are dilated, the bladder is distended. We have to think they might have bladder outlet obstruction. Now that could be due to prostate cancer invading through the posterior capsule and grabbing both ureters, grabbing the urethra. It could just be due to benign bladder outlet obstruction, but clearly it's something that we need to note in our report and possibly let the clinicians know about straight away. The patient does have a bone metastasis, but of course this may not be of immediate consequence, but our patient could have renal failure from bilateral hydronephrosis, so that's something we may wish to report urgently. So keep a lookout for hydronephrosis and bladder outlet obstruction on your scintigram. Here's a patient who had bowel cancer and came with chest pain, and we can see that there's some vague areas of activity here just between the ribs and over here. If you look, just very faint, and this is actually due to underlying metastatic disease within the patient's liver. Just going to show you a CT scan. You can see extensive metastatic disease in both lobes of the liver. So why is the tracer being taken up within metastases like this? Well, there are a number of reasons why that might happen. Increased blood flow, damage to the underlying cells, but I suppose the one that I like best and that I feel is most convincing is any damaged, dead or dystrophic tissue will have dead cells, and that includes of course tumour sites where a large number of the cells will infarct due to poor blood supply. Those cells aren't able to maintain a normal calcium pump, so they can't expunge calcium outside of them, and they accumulate intracellular calcium. Calcium gets deposited inside the cells, and then the methylene diphosphonate tracer becomes adsorbed onto these internal cellular structures, just like barnacles become absorbed onto a pirate ship that sunk many years ago. And when divers go down, they just see barnacles sitting on the cannon and the ship. The calcium accumulates in the intracellular structures, and then the radioactive tracer will accumulate on those. So potentially any damaged dystrophic tissue can take up methylene diphosphonate, and we can see them at our scintigram. So we do have to be looking out for those, because the clinician might send us a patient with the clinical information query bone metastases because they have perhaps chest pain, but we might see a soft tissue abnormality underneath it. There's other conditions where we get soft tissue accumulation of tracer. Here's a patient with activity in the heart. This is a patient with amyloid, and of course you can draw a region of interest around this, usually with a SPECT-CT, and quantify it and determine the extent of any underlying amyloidosis which the cardiologists can find useful in diagnosis. Here's one that's quite interesting and important. We've got an area of increased activity. Well, we don't know what it is, but for some reason our technologist has placed a region of interest over the hand, just like the region of interest they usually place over the bladder. So why is that? Also, I think you might agree there's diffuse increased background activity here. This is a rather grainy looking scan. Let's compare with the previous one. I don't know if you think that in this scan the bones are more clearly outlined compared with this one here, which appears rather fuzzy. There's also some activity here, and you can just see a faint focus of activity here. So what's happening? Well, this is due to a tissued injection site. So the radioactive tracer has tissued out of the cannula, or more likely a butterfly needle, which was placed to inject it, and it wasn't noticed at the time. So the tracer has gone largely subcutaneous and been slowly absorbed. So the injection site was down here in the hand. So what's this? Well, this is activity within an epitrochlear lymph node, and this is activity within an axillary lymph node. Now, it's likely that you might ask for a spot view just to make sure this is projected away from the humerus, so it's unlikely you'd mistake this for a distal humeral metastasis. But this is an important point to remember, because it's particularly important with other tracers such as FDG in a PET scan, because if this patient, for example, had breast cancer and our FDG injection was tissued, we'd see a focal area of uptake here, and you might think that was a malignant lymph node. So it's something to be aware of. So this is just soft tissue uptake this is just extravasated tracer in the subcutaneous tissues causing diffuse uptake throughout the body. The scan quality is diminished, and we can have some nodal uptake. Probably still can't see a bone metastasis here, though. I expect we would investigate that further with a SPECT CT through this area to try and confirm that. Okay, apologies again for the poor quality of this picture here. So an area of focal uptake in the right side of the skull. Could it be fibrous dysplasia? Well, I suppose it could be, but we performed a lateral view here, and this shows actually that it's within the brain, because it's clearly not in the bone, and it's clearly not within the frontal bone, and it's clearly not within the temporal bone either. So if it's not in the temporal bone, and it's not in the frontal bone, it must be in the brain substance. So the patient had a CT scan which revealed an old area of infarction here in the anterior cerebral artery territory. So, as I said, any dystrophic tissues can accumulate radiotracer, and we have to be alive to that. You can actually get tracer accumulation in meningiomas as well, but in this case it was just an old area of infarction. But it might be important to notice that, because of course if this was an asymptomatic infarction, it would be very important to initiate secondary prevention measures for the patient, not to mention not diagnosing this as a metastasis. That's obviously very important. Now, here's a very important condition which is easy to overlook. This is a patient who came with aches and pains all over their body. And I wonder if I can convince you that there's diffuse peripheral uptake here in the bones, the femora, the tibiae, and it's less clear, but there's something not quite right here in these humeri either, but the abnormality is predominantly in the lower limbs. So what is this? Well, we've done some plain X-rays, and you can see periosteal reaction here. It's not that Codman's triangle or sunray spiculation periosteal reaction we saw in a previous video of a patient with osteosarcoma. This is what's called, I'm not sure if it's laminated or lamellated periosteal reaction, and it's what we see in hypertrophic obstructive pulmonary osteoarthropathy. So what you'll see is a rather benign looking thin periosteal reaction, and there's an area of lucency just under there, if you can see that. This is the classic appearance of HPOA, and that's associated with a large number of underlying conditions: Crohn's disease, cirrhosis, bronchiectasis, cystic fibrosis, but the one, of course, that people are always concerned about is a primary bronchogenic malignancy. Here's a couple more examples. Here's some hypertrophic pulmonary osteoarthropathy changes. Same patient. I'm just going to show you this picture here. You can see a little bit of prominent periosteal reaction in the interosseous membrane, and this is actually normal. Okay, you can see this normally. Same patient, but this is actually normal. You can see that periosteal reaction down here. If there isn't a lucent bit between the periosteal reaction and the bone, it may well be normal. Here's an example where it's not normal. This patient here with a Ewing sarcoma, this is not the normal interosseous membrane appearance. There's the periosteal reaction and underlying lucency. I know this is a bone scintigraphy talk, but I think it's important to understand these plain film abnormalities in order to be good at interpreting them. And we'll just look at this patient's bone scintigram, just because it is a talk on bone scintigraphy. This was a Ewing sarcoma here. So, HPOA, hypertrophic pulmonary osteoarthropathy, diffuse peripheral uptake, like this. And the primary thing we're looking for is an underlying lung cancer. Of course, this is increased epiphyseal activity here, which we will see in younger patients. Just something here that's rather subtle, but I thought I'd mention it anyway. This patient was being staged for prostate cancer, and I just saw a vague focal area of activity here. Very subtle. So we did an X-ray, and you can see very mature periosteal reaction here, rather like callus formation around a fracture, but it's not quite a fracture. If we look at a lateral view, we can see that there's actually bone formation in the soft tissues. This is a condition called Myositis ossificans. It's due to bone formation in the soft tissues. In a way, it's similar to osteosarcoma, but it's a benign condition, and it's usually seen post-trauma. The reason I mention its similarity to osteosarcoma is because a biopsy of this area will show appearances very similar to osteosarcoma, and that's just something worth noting, so we must make sure not to biopsy it. Sometimes we are asked to perform bone scintigraphy on patients with myositis ossificans to see if it's active, because sometimes if it's painful, if we have post-traumatic myositis ossificans, if it's painful, the surgeon will consider removing it, but they will ask us to do a bone scintigram first to see if it's active. If it's showing quite a lot of activity, we'll wait, because the extent of ossification within the soft tissues may increase, and we'll only resect it when the activity has reduced to be equivalent to the adjacent normal bone. But in this case, this patient was just having a scan for prostate cancer, and it really wasn't very active at all. So that's myositis ossificans, mature periosteal reaction. Don't confuse it with osteosarcoma, and you might be asked to do a bone scintigram to see if it's active or not, and report back to the surgeon to inform the timing of any surgery to remove painful myositis ossificans. Okay, so I think we'll call it a day there, and next time we'll talk about just a quick talk on some miscellaneous fractures. Thank you.